Hi, this is Dr. Alice Lee. Welcome to iCubed. iCubed is EMN's newest blog, and I'm really excited that you're joining me. I am excited to welcome back Dr. Marc Zosky, one of my favorites, and he's going to join us with this episode. So, once again, introduce yourself.
My name is Marc Zosky. I had the honor of being on the first episode of this screencast, and now apparently I wasn't terrible, so I got invited back for another one.
Yes, exactly. So let's dive into this case. This is a case I saw roughly 12 months to 15 months ago. I seem to have seen lots of these interesting cases within the past 2 years, but this was a 53-year-old, pretty healthy, fit-looking man, and came in by ambulance. Okay, he came in with sudden onset of right-sided hemiparesis, witnessed by his girlfriend. He came in with slurred speech, and this was witnessed an hour before he came in.
So this is like our bread and butter. This is light, siren, stroke alert, stroke manager calling, everyone assembled at the CT station. We're ready to go. We got the stroke nurse who's just ready to push the Alteplase. So obviously, you're thinking, is this acute ischemic stroke?
Right.
And they're going to get a stat head scan. Mm-hmm. But whenever I see these cases, I really try to back up and go, yes, it could be a stroke. Yes, we're going to get the head scan. Yes, we're going to get rule-out criteria for Alteplase. Yeah. But there's still a broad differential for what can cause, I guess, any severe neuro stuff.
Yeah. So we are a stroke center, and because we're a stroke center, everything goes fast. The patient goes directly from ambulance bay down about 50 feet to the CT scanner. And there is an overhead call for stroke alert. So this is what happened with this gentleman. While they're getting his workup started, we have a chance to look at his past medical history because the medics are there outside the CT scanner, right? So you're talking to them, you get a history of just GERD, concussion, some migraine headaches. He's had a tonsillectomy. He is a smoker, reportedly some alcohol, and he works in IT. His meds are minimal. He's just on some Zantac. We look at his vital signs.
His vitals look great.
Yeah, they're really very normal. So then we go and examine him once he's put in the room there. He's fit. He's 53, fit-looking guy. He's awake. He's looking around. He's got slurred speech. He's very, very calm. And you start to examine him. He can't look to the right at all. His right side is flaccid completely. His right arm, his right leg. He doesn't understand what you ask him to do. He does kind of nod, but that's probably just a habit. You can't understand what he's saying. He's just slurring. But he doesn't look like he's in any distress.
Mm-hmm. So it's a pretty severe neuro exam.
Yeah, exactly. 53 guy with hemiparesis. So again, everything comes back very quickly. The labs are back. They look fine. H&H. The CBC is fine. Your basic metabolic looks fine. Nothing out of the ordinary. His EKG. So his EKG was a normal sinus. There was no AFib or undetected AFib or anything like that.
Did we show the chemistry before? I forget.
Mm-hmm.
Was it?
Yep. So there's regular,
I just want to see that glucose because I feel like would be the most embarrassing thing in the world is if you're the guy calling neurology going, hey, I'm starting Alteplase on this guy. He's got an acute ischemic stroke. And then the chemistry comes back with a critical of, hey, his glucose is 35. And then you start sweating and go, yeah, I went to residency. I know what I'm doing.
That is a fantastic point. I appreciate you being on these episodes because you make these great educational
The AccuCheck. It's the thing that EMS always does, but we always have to remember to look at it because I think I was working a shift the other day where it came in as a stroke alert. It actually came in as a stroke alert with a blood sugar of 35.
What?
And then we, me and the nurse who took the call who were smiling/crying, going, well, did they give any D50 and reassess? And they didn't end up being fine. So that's just my pearl is we always have to remember our AccuCheck.
So that patient was not a stroke?
No, that patient got some sugar and then looked amazing.
That is, even though it seems so simple and basic, it happens. It happens.
I know,
yeah,
it does.
It obviously did. So once again, the EKG on this patient was unremarkable, just a sinus rhythm and no AFib. that you always think about.
Here's the big transition point.
So within that first few minutes, you get your CT scan. It's red. The findings are most consistent with a subtle acute infarction within the left basal ganglia.
And I'm surprised we even see the acute infarct if it was like 1 hour after on CAT scan.
Exactly. So this is a little bit of a surprise. There's a hyperdense left MCA consistent with an arterial thrombosis. Right? So you're like, oh my God, this is something like happening at this moment. It's a thrombotic stroke, right?
Yeah.
There's otherwise sort of minimal findings. So with this patient, with this finding, immediately he qualifies obviously as a TPA candidate. So we start that Alteplase, but we go ahead and order the CT angio, right? With perfusion, and that comes back also fairly quickly, and it shows us this critical stenosis of the origin of the left internal carotid artery. There's poor enhancement of the left MCA artery, and the CT perfusion portion of the scan shows poor cerebral perfusion to both cerebral hemisphere, but much more so on the left MCA distribution. So in the meantime, we have already established by this time, this patient, that we can call the stroke neurologist anytime and let them know about any patient with doing a CT angiogram, and then we're considering endovascular on, because the stroke neurologist can actually look at the scan themselves before the radiologist reviews it or interprets it, right? That way you're saving some time. So if you notify the neurologist, the stroke neurologist, as you're ordering a CT scan, and our stroke neurologist is down at Banner University, the endovascular interventionalist.
So what time did this happen again?
It was in the afternoon, 1400, like mid-afternoon.
Okay, good. So obviously people have not gone to sleep.
Yeah, exactly. So unfortunately, it does matter. But anyway, in this case, fortuitously, it was mid-afternoon. I was able to get in touch with the stroke neurologist downtown at Banner University, who was able to take a look at the scan even before the radiologist was able to look at it. But we get the official report in the ER that there is an acute thrombotic ischemic stroke going on with this guy. Yeah,
and it's actually rare we get people that come in this fast,
Very rare.
Get Alteplase on that fast, and then you're still in, the golden 6 hours where you would want to, give your TPA within 3 hours and get your endovascular clot retrieval within 6 hours. So this potentially could go very, very well,
or not. We'll find out, right? We'll find out. Okay, so while we're getting ready for us to transfer him downtown, the stepdaughter comes into the ER and says that the patient had a TIA about 3 years ago. We didn't get that history at all, and she reports that the family has a really strong history for stroke. So that, of course, makes us all even more kind of concerned. But it makes sense too, because he's a young guy with a devastating stroke. In the meantime, I'm looking at the patient now as I'm talking to the stepdaughter. The patient's sitting there on the bed. He's like in no distress. There's little kids in the room. He's chatting with them, smiling at them. But he's totally unaware that his right side is out. So he's got a complete right-sided neglect. We did go ahead and transfer the patient over to Banner UMC. He underwent endovascular aspiration of acute thrombus in that left MCA, and he was stented. So I followed up on this patient. I believe I even followed up that same day because this was all happening so quickly. And there were some images that I was able to find, and this is great. This is just an awesome set of images. So you'll see at Banner UMC when they did the angiogram over there, there's a complete cutoff right here. Right? And then you'll see afterwards, after they retrieved the thrombus and stented it, there's much more flow afterwards. So it was really remarkable to me on this gentleman. And if we look at the timeline of this patient's care, he had come into my ER about an hour after the onset of his hemiparesis. He got his TPA started at roughly 90 minutes. This scans were all done within that period of time. We transferred him down really quickly over to Banner UMC. About 60 minutes after that, he got stented and he had an embolectomy. And then at discharge, a couple of days later, he had very, very minimal deficit.
That's amazing.
I know.
That's
amazing. Great
I
case. I looked at PT evaluation on the patient's chart, and they documented 5-/5, right, upper extremity weakness. Just very, very minimal. Great case.
Yeah. It's nice when they go well. I'm always scared with your cases, Alice Lee, because potentially I'm like, I think I know what's going on, but the next slide is going to show me something where something horrible happened to somebody. So I'm glad when they go well, because we see so many strokes that are so devastating.
Yeah.
And this is good, especially a guy that's in his 50s that has his whole life.
Right. Okay, so with each of my episodes, I would like to leave us with 2 learning focuses. And this first learning focus, what do you think?
Learning focus number 1.
Yeah. So when this patient came in, I actually fortuitously, about 2 weeks before this, I had been listening to MRAP. And there was a very quick blurb about Mr. Clean, a study on endovascular intervention for ischemic stroke.
Oh yeah, there's like the 3 big ones. Mr. Clean and was one of them.
Well, I wasn't really following, all these different studies, but this one particular episode was interesting, and Mr. Clean had just been released. It was January of 2015. It was a small study, and it was just the preliminary results, but it had showed very positive results on a select group of patients. So when this patient came to the ER, the first thing that came to my mind was that endovascular intervention, was it possible in this man? That's why I think at the moment he was in the CT scanner. I ordered a CT angiogram because it just came to me. I thought, didn't I just listen to a CME a podcast about endovascular intervention? And this guy kind of fits in that category. So learning focus number 1.
Ooh, keep up your CME.
Because honestly, I'm not sure I would have expedited that study of the CT angio if I didn't just have that fresh on my mind 2 weeks prior to this patient presenting that, these are the patients with a devastating hemiparetic large stroke are the candidates for the endovascular. So focus number 1 really is that we want to keep up with our CME. I mean, medicine is constantly changing. There's more research, there's more studies. And so in my 24 and a half years, I've just never stopped learning. I go to conferences on a regular basis. So I really, really strongly believe in continued medical education and just being a lifelong learner. And I honestly believe that in this guy's case, because I had just listened to a podcast, it helped me expedite my care on this guy.
Yeah, and if he got his CT angio, 7 hours later when the neurologist came down and put some orders in or something, and then got transferred, if they still wanted to go ahead and do clot retrieval, and if it got done 12 hours later, you never know if it would have helped at all. So to get done this fast, there's few things we have to do in emergency medicine that are like this time sensitive.
Yeah, exactly.
And 1 is the Alteplase, then 2 is the clot retrieval.
Yeah.
So, yeah.
So keep up your CME, everybody. Focus number 2 is related to focus number 1. In this particular patient, obviously it was a very nice, very successful story, high-fiving everybody, and we were able to minimize any stroke deficit. But really, I do want us to remember to look out for those patients that are candidates for endovascular retrieval. And this is a very small group of strokes, okay? Probably 10% or less of acute ischemic stroke will fall under this and will benefit from this. We've seen lots of stroke patients in our hospital because it's a stroke center, but this is one of maybe a handful that actually had successful endovascular retrieval, even though I've sent multiple patients away to get endovascular retrievals. However, after this particular case, I really became a fan of endovascular intervention for acute ischemic stroke.
I love it when it actually happens, but your case was like so perfect of, the onset got them to the hospital so fast. We got all of our imaging so fast. I mean, the CT non-con even showed an acute infarct, which, we rarely see, especially when it's only an hour. So, yeah, this case just went very well and smooth. I've had many, many patients I wish I could have sent over, but, oftentimes for whatever reason, we're 12 hours out, and the interventionalist doesn't want to do anything. I mean, probably because it wouldn't help.
Right.
But, yeah.
Right. I want to go over the Mr. Clean study just briefly. This was January of 2015. So this is some information about that particular study, Mr. Clean study. There were some very positive results in a very small select group of acute CVA patients, right? These were all large proximal CVAs. The CT angiogram demonstrated an arterial occlusion. The CT perfusion scan demonstrated a penumbra, which is that sort of in-between brain matter that could die very quickly if you don't attend to it and bring more blood flow to it. All of these patients in the study had systemic alteplase infused within the 4.5 hours, and the endovascular interventions were all within 6 hours. So these were all the criteria these patients met. The authors concluded, or one of their statements at the end was that there was a shift in the distribution of the better outcomes in favor of the intervention. Well, what does that mean? In the article, they had this graph that had compared the results of those patients who had the endovascular intervention versus those who were controls. Now, I went through this carefully to understand. I don't use the modified Rankin, but the modified Rankin scale is the most commonly used scale for to measure stroke disability, and also to use for measure for outcome of stroke trials. If you look at the chart, you can see that the Rankin scale goes from 0 to 6. Okay, and bear with me as I go through this with you a little bit in detail, because I think it's important. But they compare the patients that had intervention, their results, and with the controls. So like I said, the modified Rankin is a way to compare the disability between stroke patients. And the comment of the authors was that there was a sort of a shift towards a better outcome. What does that actually really mean? If you look at the chart, 4 means unable to walk and 3 means able to walk. Okay. 51 patients in this study that had endovascular intervention was able to walk at baseline after their stroke versus only 43. If you look at the patients with modified Rankin score of 2 and below, that's a more significant difference between the two groups. There were 33 patients in the endovascular group that scored 2 and below, meaning 2 or better, versus only 19 in those that were the controls. Now, my thoughts when I went through this was this. It sounds like these are very small numbers, right? 51 versus 43, there's like 8 patients. One is, there's 8 patients more that can walk versus can't walk. But my father actually was bedridden after he had a subarachnoid hemorrhage. And for people who are caregivers for these patients, for instance, those 8 patients that are walking now because of the endovascular intervention, versus those who are not able to walk after, without the endovascular, it really is. It is a huge deal for the caregiver. Yeah.
Oh yeah, for the patient and their family. When you can't walk, your morbidity and mortality goes up. Once you can't walk, it's potentially all downhill from there. It's not good.
Well, I've always thought, bigger numbers for studies are better, and that's true. But when I looked at this, I realized, you gotta tease that out a little bit. It really makes a big difference between walking and not walking.
Oh yeah.
Even if it's one person.
Oh yeah.
Even if it's like 8 patients that are now able to walk versus not able to walk. And so even though these are small numbers, then there are only like 233 patients that were studied with endovascular intervention versus 200 something that did not have endovascular. The results are, I guess, in real life, very meaningful for those who are able to walk versus being minimally disabled or being bedridden. Not just for the patient, but for the patients that are being, for the caregivers. My mom had to take care of my dad, who had to be hoisted up with a Hoyer lift from bed. He had a colostomy, and it was just...
It's a full-time job.
Yeah, it was. It was very difficult for a time of my life when I had little kids to take care of as well, and about 15 years ago. So when I started thinking about, in real life, what this really means, then I was convinced that this study was meaningful, I guess.
Yeah, and there's two other big ones. I think it's the Escape something or other, and there's one other big one, and they all showed positive data for endovascular. And, granted, we wish we had larger sample sizes, a larger N value, but the criteria is very specific.
Exactly.
That's the thing, to get your patient to have all the rule in or rule out criteria within 6 hours is not easy to get, a sample size of thousands of patients, multi-centered study. So.
Right.
I think with the best data we have, it obviously supports this, especially with, obviously there's controversy with Alteplase in general, but this has much stronger data, depending on where the fence you stand for the Alteplase. I think this is clearly indicated in select patients.
Right, I agree. So I think the second lesson in this episode really is to keep your eye out for those patients that are going to fit this criteria and get them to the interventionalists. I do have to comment that within the past few months, I've had varying opinions of neurologists. Some neurologists are very, very aggressive about this, even if it's way past 6 hours. Okay? And at the same time, I've got neurologists who are going to stick to the rule, with the criteria, which is, if we're not going to get the patient over to the facility by 6 hours, it's really not quote unquote worth doing, because the studies don't support that, versus other neurologists who are saying anecdotally, we've had patients successfully treated with endovascular even way past 6 hours. So
it's tough.
That's a struggle. That's a daily shift to shift struggle with your neurologist. Oh
yeah, and I feel like a lot of it's your particular practice setting and community, and what your team does, and what your local neurologists do, and I've I've had a neurologist advise TPA at an NIH of 1, on a 90-year-old, and other times other neurologists would say that's crazy. Why would we do that? Exactly. So there's so many differing opinions on how we should do this. And we're all just essentially doing the best we can on a devastating illness that there really is no cure for. Yeah. May I add my own learning focus,
Please
Dr.
do.
Lee?
Yes.
Okay, if I dare. I will add learning focus number 3, which is we are the first hope of the differential diagnosis of not just thinking acute ischemic stroke or acute hemorrhagic stroke, acute ischemic stroke. So my learning focus is still just always remember your differential. Obviously this one was easy because the head scan was so powerful. Yeah, exactly. But what if the non-con head CT was normal? Yeah. Is this a complex migraine? He had a history of migraines. Obviously the neuro exam was, pretty devastating. It wasn't just someone that said they couldn't move their finger. Right. But is this hypoglycemia? Is this, here's a crazy one that I actually saw once, was tic paralysis. What? Tic paralysis.
Hemiparesis?
Mm-hmm.
Wow.
Tic paralysis. And luckily the PCP had already diagnosed the patient, because I wouldn't have. They did a hair exam and pulled the tick off and brought it with to the ER. And everyone was standing around like they knew, we would have seen tic paralysis. And I'm like, unless the patient told me that their PCP took the tick off, I would have no idea.
Exactly.
What else is, so I always try to think of the other stuff, because, sometimes when we consult our consultants, and this is nothing against them, when you're holding a hammer, everything looks like a nail. So neurologists are looking to push Alteplase. Yes. So we still have to think of the bigger picture.
I think that's great. In this kind of a situation, though, we want to make sure to cross the T's and dot the I's, right? You have to get the angiogram. That's what's going to qualify a patient for endovascular, because the angiogram is going to show you a clot. Mm-hmm. If the angiogram is clear, then there's just no reason really to send the patient. because it's not cost effective. It's very expensive to either fly, and the stroke neurologists oftentimes want us to fly these people over to their center, because we're not the tertiary center. So I think that for me anyway, that just getting that CT angio quickly, right at the beginning. And I believe that we're going to implement sort of a protocol where the CT angio is going to be done almost simultaneously in those patients that qualify. That's kind of cut down on the waste and cut down on the overuse of this protocol, because once again, the endovascular retrieval is really only effective on a very small select number of patients that come in with ischemic stroke. So for me, I definitely keep my eyes open more and more, and I have kept my eyes open more and more since this particular stroke case of mine, and those who are devastating hemiparetic large strokes, or even those who have, you think it's a posterior circulation stroke, that's one of the criteria as well, then those are the ones I order the angiogram, like right there. They're in the room already for the plain CT. I'll order the CT angiogram, and then I'll get a stroke neurologist on the phone pretty quickly after that. So.
Great case, Alice. Great outcome.
Very good. Thank you, Dr. Zosky, once again.
Thank you for having me.
Thanks, everybody, for listening and watching. I hope you have learned something from us, and we'll see you next time. Bye.
Bye.